Good evening, ladies and gentlemen. My name is Montio Morgan, and I am a member of CamDocUK, the Association of Cameroonian Doctors in the UK. It is my pleasure to welcome you to our 20th CamDocUK Talking to the Community webinar. We at CamDocUK are passionate about engaging with our community across the globe. And you can find our previous webinars on our social media outlets, including YouTube. This one is being shared and streamed live on YouTube, and our website, www.camdocuk.org. Now, I will ask you to please like, share, and subscribe to our social media websites, because that helps us to do better work for you, our community. It is my immense pleasure also to introduce the people behind the scenes, behind our CamDocUK Talking to the Community website, webinars, without whom this would not be possible. Our education lead is Dr. Gael Nana. Our chairperson, Dr. Linda Bello.
Hello.
Our social and communications secretary and the absolute whiz kid of all things IT in CamDocUK, and honestly, without whom this would not be possible, Dr. Anna Bene.
Hello.
And behind the scenes, we also have Dr. Mafo Foma, who is going to be fielding your questions and sending things flying left, right, and center, wherever they may need to go. Thank you. So we have called this webinar a breast lump, a journey from discovery to treatment. And this is because breast cancer is not by just by mistake that I'm dressed in a pink t-shirt. A breast cancer is a big problem across the globe, and also specifically for us Black women. What we're going to do today is we will have a series of 4 absolutely passionate people who will give us their perspectives on how to deal with breast lumps, going from a general practitioner or a family physician, as they are called, general practitioner as they're called here in the UK, who is the first port of call for a patient when they discover a lump in their breast. And she'll tell us, Dr. Manka Timi will tell us what is done initially for the patient. And then we'll go on to my friend, Mrs. Jackie Eko, who 10 years ago, I can't believe it's that long, discovered a breast lump. And she is going to tell us all about her journey. Please listen, because her story is absolutely spellbinding. We will then go on to talk to, or to hear from Mr. Ali Jahan, who is a specialist breast surgeon and breast and oncoplastic surgeon, who is my colleague. I work in Nottinghamshire. And because I knew of the good work that he does, I connected Mrs. Eko to Mr. Jahan. And so you will have a 2-pronged approach to how her breast lump was managed. We will then round up with Dr. Munouh Foma, who is a hematologist and oncologist working in Albuquerque, New Mexico in the United States, but who came from the best medical institution in Cameroon, just because I was trained there, the Faculty of Medicine and Biomedical Sciences in Yaoundé, Cameroon, and who will tell us, who will give us his view of how to manage a breast lump from the oncology side of things. So it is absolutely, before I go on, I've been reminded that I need to tell you, if you have any questions, please put them down below in the Q&A box. If you put them in the chat box, my team of IT whiz kids will encourage you to put them in the Q&A box. And that's because it is easier for us to manage them, to keep an eye on them and manage them. So we will aim to answer all your questions between now and when we finish at about 7:30. Even if we don't manage to finish, we will be able to make connections so that we can answer all the questions that you have. In the chat box already, you are here, you can see welcome messages and encouragement to put your questions in the Q&A box. Towards the end of our webinar, we will have a poll which will be sent out by Dr. Mbene, and that would also help us to make things better for you. Right then, I'm so excited to start. We will start, and first I would like to invite Dr. Manka Akumah Timi, who, as I said to you before, is a primary care doctor here in the UK. She works in Portsmouth and Gosport. She trained at the medical school in Douala in Cameroon and then relocated to the UK to do her specialization in family medicine. And she has a special interest in sexual and reproductive health. I must say that I am really delighted to have Manka on the webinar because she has been working, she has had to work up until about 15 minutes ago. So thank you very much for your assiduousness, and you have the floor, Dr. Timi.
Hello. Thank you so much. Thank you so much, Dr. Morgan. I'm pleased to be here, and thank you to everyone who's shown up on time. We're expecting a few more and hope it's going to be a very educative session for everyone. I'm going to go ahead to share my screen. I have a few slides that I wanted us to talk through. So it will be that one. There we go. Is that visible to everyone? Yeah. Okay. Right. So Mamima has beautifully introduced me. Thank you. We're going to talk through just what breast lumps are and talking through the types of breast lumps. There's a vast majority of them. I would mention the common ones. We'll talk through self-examination and what we would recommend if you find a lump. Also what to expect from your GP. And then we're going to go through a holistic approach to treatment and some screening recommendations. So a breast lump is a growth or a mass that develops in the breast. Some women find that their breasts are naturally quite lumpy and that it could be even more lumpy just before a period. And so we strongly recommend everyone know what your breasts feel like. Check your breasts before your periods, during your periods, so that you know what's normal for you and what isn't. When we talk about breast lumps, we want you to think about armpit lumps as well. We have glands that are located in the armpit, located everywhere all over the body, but the glands in the armpits are quite connected to the breast itself. So it's important that when you're checking your breast, you check your armpits as well for any lumps that may be there. Typically, these glands are lymph glands. They are like our immune system. They tend to swell up when there is any local infection or a cold. And so the likely reason for a swollen lymph gland would be an infection. Nonetheless, if you do find one, it's important to speak to your doctor about it to make sure that it's nothing more sinister. So the general piece of information would like you to know is that most breast or armpit lumps, most breast and armpit lumps are not cancer. That means they are benign. So in terms of the types of lumps, we have benign or the non-cancerous lumps and malignant lumps, which are the cancerous lumps. Again, generally 8 out of 10 breast lumps are benign. That's non-cancerous. Benign lumps include things like breast cysts, fibroadenomas, what we call benign fibrocystic masses of the breast. There are also some benign lumps that are caused by infection, like the good old abscess or mastitis, which is what you'd see commonly in breastfeeding women. So breast cysts, the word cyst just means a sac of fluid, and that could form anywhere in the body. So it can form in the breast as well. So it's just fluid-filled sacs that build up in the breast tissue, and they would typically affect women over 35, but it could really be in women of any age, and they could be multiple, one single cyst, or in both breasts. They vary largely, and sometimes it could be painful. But it's important to know that breast cysts would not increase your chance of getting a breast cancer. So the other common type of benign lumps is what we call fibroadenomas. That comes from the word fibrous. Fibrous is just like scar tissue. So fibrous glands or fibrous glandular tissue could form in the breast, usually like a smooth lump that you would feel in the breast, typically in younger women, and they do not need to be treated. Again, this is not a type of lump that would increase your risk of developing a cancer. And then we have the fibrocystic breast changes, which is a general term that is given to just lumpiness and thickening or swelling in the breast tissue that would typically happen before periods. In some women, draining the cysts or the fluids that form in the breast would relieve their symptoms. This is not something that's going to increase your risk of cancer. And now we get to the malignant lumps. Case study breast cancer. So breast cancer is a cancer that starts in the breast tissue, and it's the most common female cancer in the world, which is why we really want to push this a message out and encourage women to be more breast aware. So symptoms would include anything from a lump in the breast or change in the skin of your breast or thickening in the breast, nipple changes. We'll talk a bit more about these signs ahead. There are generally better survival rates when a cancer is picked up early. So in terms of risk factors, a risk factor is just anything that increases the risk of you getting a particular condition. So I've listed a few modifiable risk factors, which just means things that you can change, and a few non-modifiable risk factors, which are the things that you cannot change, but it's worth being aware of. So things like being overweight or obese is going to increase your risk of cancers, many cancers, including breast cancer. Also, alcohol intake. If you're taking excessive amounts of alcohol, you're putting yourself at a higher risk of having a breast cancer and many other types of cancers. The UK recommendations are to have anything less or not more than 14 units of alcohol. That's equivalent to about 3 bottles of beer in a Cameroon setting. Also, things like hormone treatments that you'd find in combined contraceptive pills or hormone replacement therapy would increase your risk of developing a breast cancer. In terms of the non-modifiable risk factors, the list is exhaustive, but there is the family history that it's important to be aware of. It's important to know if any members of your family have had a cancer, what type of cancer, and if it's a close relative, what we call the first degree relative, which would be your parent or your sibling, it's important to be aware of this and speak to your doctor about it, because in the UK, we do have the genetic testing centers where we can refer you to have testing for any inherited genes, cancer genes. So that's important. Also, just quickly, ethnicity, there's a quite close link between the rates of breast cancer in Black and white women. But studies have shown that Black women tend to have more of the deadly types of cancers, and they are easily determined more in the late stages. So that's also important. We tend to, in my practice and in most GP practices, Black women with a lump, we tend to really refer them to the breast clinic for assessment. So speaking of breast examination, self-examination, The best way most people do it is whilst they're standing in the shower and they just have a feel around their breast. So you could be standing in front of a mirror, maybe after your shower, feel around your breast, follow a strict pattern and keep the same movements around the breast, feeling for any abnormalities. Also feel your armpits, squeeze your nipples, and move up and down as you examine yourself. If you're in bed at night, you can also have a feel of your breast. And generally, we say monthly examinations are ideal so that you pick up any strange or new findings in your breast. So someone has done their self-examination, someone has found a lump. What should you do next? Please do not self-diagnose. Contact your doctor immediately for an assessment. What your GP is going to be doing is going to ask about your general health, ask about symptoms around your breast, ask for any family history of cancer, ask about your social history, smoking, alcohol, ask about any hormonal treatments that you've been on, and then they're going to examine your breast thoroughly. They're going to examine for any lymph nodes in your armpits or around your neck region. If something's found, what we tend to do in the UK is refer to a one-stop clinic, the breast clinic, where you're going to have, a wholesome assessment and imaging. And this is why we really strongly recommend that, patients who notice any lump should show up to their doctors, because there is such a clinic where you'd have exhaustive investigations done as appropriate. And if there's a need for a biopsy, that can also be done in the breast clinic. The aim of treatment is to remove any cancer or to control the spread of a cancer while preserving your quality of life. Typically, your medical team is going to give you a combination of either surgery or chemotherapy and radiotherapy and immunotherapy. It's going to be a specialized or personalized plan specific to you and the type of cancer or the stage of the cancer that's been found. The holistic approach to treatment is to talk about or to be aware of the emotional impacts that breast cancer has on the patient and on their loved ones. It brings on a range of stress, sadness, fear, anxiety, and many, many emotions like this. It's important to be aware of this and to acknowledge how it can take a toll on your mental health and prioritize your mental well-being. Mental health affects physical well-being as well as non-physical well-being. So you need to practice mindfulness, meditation, yoga for some, and keeping a positive outlook on life. Also, it's important to seek support, be it from friends, from family, from any groups that you belong to. Seeking support is important if you've got a cancer diagnosis. So in terms of screening recommendations, in the UK, we recommend that women over 50 have their mammogram every 3 years. Mammograms are low-dose X-rays that can detect cancers that are not felt or that cannot be seen. So it's a quite important test. So we do recommend that for over 50s. In the US, over 40s, they have to do a mammogram yearly. And again, in women who've had a really strong family history of breast cancer, speaking with your GP or to your health provider is going to enable you have early genetic testing. And if there are signs of you having the inherited gene, you can get screening sooner than 50 or sooner than 40. So just a general slide to talk about how you should take control of your own health, self-examination, maintaining a very healthy weight, healthy diet. We recommend physical activity of about 150 minutes in a week. So that's about 30 minutes a day, 5 days a week. Discuss any hormone therapy risks with your provider. Limit your alcohol intake as much as possible. And then just a word of empowerment. It's important for people, despite going through a challenging diagnosis such as cancer, still find the means to empower people in your community, speak to them, connect with other survivors, appreciate life, be an advocate for early detection and support fellow fighters, share your story and inspire people. On that note, thank you very much for listening. And we'll deal with the questions shortly. Thank you.
Wow, what a positive way to end your talk there, Dr. Timi. That's fantastic. The takeaways for me, first of all, is that not every breast lump is a cancer. So it's not one, if you discover a breast lump, you need to do something about it, but don't immediately start catastrophizing.
Yeah.
Do something about it immediately, as soon as you possibly can.
Yeah.
And we have some questions for you. Somebody has asked whether it is possible at some stage to demonstrate live how to check for the breast for lumps. I think that I might get into trouble with the morality police if I strip off my T-shirt on this webinar and start showing you how to demonstrating how to check for breasts. But as Dr. Timi did quite rightly show on the pictures, there were, you do it in front of the mirror, put your arm up, and then follow all the way around your breast, take it wedge by wedge, moving inwards and just feeling it, and then pinch it so that you can feel if there is any abnormal lump. And don't forget your armpit or the axilla. And do this regularly. Also do it while you're lying down in bed, because that then spreads the breast tissue so that you can feel for the lumps. I hope that answers your question.
Yeah.
Now, there is another question specifically to you. There's one of the attendees who says she doesn't feel confident examining their breasts, or they don't feel confident examining their breasts. Can the GP help with this?
Yes. Hello. So, like we said earlier, the GP would definitely be able to help if there is any abnormality with your breast tissue. If you're not able to examine your breast, I believe communicating this with your GP would also be helpful. You would be able to be brought into the surgery and have a session just to talk through it. If it's not going to be your GP, it might be a nurse who's going to help talk you through that process. There are a few videos, YouTube videos that we can get with what do we call them? Mannequins of examination. I'll try to find one real quick and put a link in the chat so that that person can have a look at. Yeah.
Thank you very much. The next question here, which might possibly come to yourself, or maybe Mr. Jahan could answer later. It says the patient, the attendee says they're only in their 30s, but they have one aunt with a family history of breast cancer, and they are worried and want to have a scan. Will they be able to have one? I suppose that would depend on where they are, and possibly what we can do. What I would say is possibly the best thing would be to contact your GP if you are in the UK to ask what they would want to do. What would you say to that, Manka?
Again, we talk about first degree relative, which is your parent, immediate sibling. Typically, if you've got a family history in such a person, then that's a good reason why the GP can refer you on. So, in order to get a scan, it would be tricky with the NHS, right? It's not fitting any box really for a routine scan. So in the absence of any symptoms, you might be redirected to do that privately. You can certainly have a scan privately. But how the NHS works is, there should be cause and a good reason to initiate any investigation. So the fact that it's in an aunt, if you're not having any symptoms, they'll give you a lot of reassurance, because it's also, not a direct link. But if you absolutely want a scan, you might be asked to get that done privately. I don't know if any of my other GP colleagues has something different.
No, I think that's perfectly fine, and we'll go on from there, and it might be that possibly other questions come up to support that. There's another question in the chat box from Marie Claire, but we'll come back to that in a minute. Okay. If I could get you to stop sharing your slides, Dr. Timi, thank you very much. Great presentation, really, really fantastic. Our next speaker is Mrs. Jackie Dioh Eko. She is an educationalist and the founder of Dewey International School of Applied Sciences in Douala, Cameroon. Mrs. Eko lives in Douala, and she is passionate about empowering our youth and future leaders in everything that she does. She, as you will hear, is a fantastic person. 10 years ago, she discovered a lump in her breast, and her life came to a screeching standstill. I am very grateful that Mrs. Eko has agreed to come today on CamDocUK Talking to the Community webinar to share her story in the hope that that would increase awareness and improve outcomes for breast cancer. Welcome, Jackie. The floor is yours.
Thank you very much, Montio, for that beautiful introduction. And I want to thank you all for giving me this opportunity to be a panelist on your prestigious CamDocUK webinar. I'm really thrilled to be here with you, sharing my journey through cancer. And as Montio said, I'm Jackie Eko. I live in Cameroon. It was a roller coaster for me, and I think it always is a roller coaster when I have to share my story. But I want you to listen carefully to me as I go through my story from diagnosis to triumph. So in 2013, I was diagnosed with breast cancer. But the good news is that 11 years later, here I am, cancer-free and going on stronger than ever. And I want to say I want to think it's because of the fact that the diagnosis was done early. So there was an early detection of the cancer. So that's one of the things which I think was beneficial for me. So how did it all happen? From my early years, when I was in my early 20s, I've always been very conscious of my health. I always did my yearly examinations, physical exams. And by the time I was 30, I started doing mammograms simply because I had fibrous breast tissue. So I started doing mammograms every other year. And each time the mammogram results would come, I was told nothing to worry about. I just had fibroadenoma, just like Dr. Manka has mentioned. So there was absolutely nothing to worry about. And I was always happy. But in my late 30s and somewhere between my late 30s and early 40s, I now discovered a lump in my left breast. And when that lump was discovered, of course, I continued with my routine tests, mammograms, physical exams. And I was still told nothing to worry about. You've got fibroadenoma. I remember one time actually making a trip to the UK just to get a second opinion, but I got the same results, nothing to worry about. But one fateful day in August of 2013, as I was doing my self-breast exam, I noticed that the lump was a little bit different. It felt more prominent and it was more mobile. So I spoke to my husband, Kenneth, about it, and we immediately took an appointment to see the doctor. So when we saw the doctor, of course, he ordered a mammogram, which was done. And after that, he suggested that we do a biopsy, which we also did. And he sent out 2 samples. One sample was sent to Centre Pasteur in Yaoundé, and the second sample was sent to a lab in France just for further analysis. And I was told that I had to wait for 1 month to get the results. So the results were going to take 1 month for me to get them. So of course, you can imagine that was the longest month of my life. It was very nerve-wracking. But that notwithstanding, I was still, I was optimistic simply because I didn't think I had the typical risk factors for cancer. There was no history of cancer in my family. I didn't smoke. I didn't drink. I ate very healthy food. I exercised 5 times a week. And I took good care of myself. So where was cancer going to come from? It couldn't happen to me. You understand? So that kept me optimistic anyway. Then exactly 1 month after the samples were sent for biopsy, or the biopsy samples were sent out, I got the phone call, that phone call from my doctor. And he said, the results are out, so I need to see you at 4 p.m. So of course I called Kenneth, my husband, and I said, hey, we have to go and see Dr. Kuang at 4 p.m. And when I finished speaking to Kenneth, I got a little bit worried because normally this doctor is someone who's very chatty. So I said, why didn't he just tell me on the phone that, hey, the results are out, but there's nothing to worry about. But anyway, just come and see me. So I got a little bit worried and I felt like not going. I didn't want to know the results. But the lovely husband accompanied me to Dr. Kuang. We got there and he gave the results. But of course, before giving the results, he wanted to do his chatty thing, getting you to get to laugh and all of that. But I was not interested. I just wanted to get the results. So I just needed him to get to the point. And he gave me the results. And this is how he put it. He said, they found cancer. Oh my goodness. Those 3 words, very powerful words, those words changed my life. Because at that time in Cameroon, cancer was like a death sentence. You have cancer, oh my God, you're going to die. It's just a matter of time. So when you hear you've got cancer, it's like, okay, does this mean I'm going to die? So it was a real emotional, I got very emotional. I think I don't remember hearing anything else the doctor said after those 3 words because I was in a different world. I remember crying all the way, just weeping tremendously all the way home. The whole evening I was weeping and crying. I didn't sleep that night. The next day I had to give this information to my family. I remember calling my sister in the UK, Becky, giving her the news. She was crying on the phone. Her colleague who was breast cancer survivor came in and gave me advice, but everybody was just crying. My mom was crying. My brother in the US, everybody was just very emotional. So it was very, very difficult. And I went on like this for like 2 weeks, just crying, couldn't even get out of my room, couldn't get out of my bed. I was just very, very miserable. But once I picked myself up, I started doing a lot of reading and a lot of research, finding out how did this happen? Where does it come from? What are the treatment options? I remember at some point, my doctor had given us some treatment options and he talked about chemotherapy, he talked about radiotherapy and also surgery. So, but he suggested that surgery would be the best for me. So I did all my reading and everything. And also as a Christian, I did a lot of praying. My prayer life went to gear 5. And I am a natural person. I love natural treatments. I'm on a lot of, supplements and so on. So I have this internal medicine practitioner whom I usually, consult with. So she too was giving me her own advice. And I was totally confused. I had all these conflicting ideas or advice from, my prayer pals who said, just pray and God will heal you. And the internal medicine or the alternative medicine practitioner who said, go on a raw diet for 3 months and the cancer will go. And then there was surgery. So what do I do? The most difficult thing for me was to discern what God wanted me to do because I wanted to do what God had planned for me to do. So a turning point came when I received a phone call from one of my prayer pals, and he said he had a message for me from God. And this was the message. He said, the message said, go to the UK, test and die, or stay in Cameroon, pray and leave. Oh my goodness, what a message. So that just put me into a total mess. I was so confused. And of course, as a spiritual person, I was leaning more toward the spiritual advice. So I decided, okay, I'm not going to no UK. I'm not taking any treatment. I'm just going to pray and leave. I refused to go for the visa. I refused to speak to anyone. My family was calling, what are you doing? Have you gone mad? Are you crazy? My husband was receiving tons and tons of phone calls a day. What is she doing? What has she decided? What's her mood like today? It was a total mess. Everybody was just in an emotional turmoil. And I realized in all of this, I was not at peace at all with myself. So I decided, okay, I want to seek counsel from God. So I decided to retreat for a few days. I just locked myself up in my room, just pouring my heart to God, listening to him and trying to find hope and so on. And about 3 days later, I got a realization, got the feeling that God was saying I needed to do the surgery. So I came out of this retreat very positive, and I decided I'm going to go to the UK and I'm going to do the surgery. So Kenneth and myself went out and applied for the visa. We hardly had enough time because I'd wasted so much time, confused, so we applied for the visa, which takes about 3 weeks, and got ready to travel. And fortunately for us, the visa came the exact day we were supposed to be traveling, because my in-laws and my friend here, Dr. Montio Morgan, had already taken an appointment with Mr. Jahan for the 9th of December. So I had to travel on a specific date. Fortunately, that visa came on that same day. And for me, that was just like, okay, God is on my side, because this is just a miracle, So we traveled to the UK and we had our first appointment with Mr. Jahan, which was, that appointment actually brought a lot of mixed emotions to me. But being the patient and understanding and very positive person that Mr. Jahan is, he explained everything about my situation to me. And he actually did another battery of tests. So he repeated the mammograms, he repeated the biopsies. And if I remember correctly, I think they even took some samples from my lymph nodes and also tested those. And when the results came out, it confirmed invasive cancer and DCIS, something like that. Yeah. So that warranted for surgery. So the surgery was programmed for the 20th of December. That was like maybe 1 week after this appointment, or 10 days after the appointment with Mr. Jahan. So I went in for the surgery, which was very successful, and stayed in the hospital just for a few days, maybe a couple of days, after which I just came in for routine wound care. But Mr. Jahan had given me 10 days or so after the surgery to come back for, feedback, my all clear, because there was still, even though the surgery had been done, there was still the lingering possibility of, should I go for chemotherapy or not? Do I need chemotherapy or not? So Mr. Jahan once again suggested a test called the OncoDX test, which was supposed to determine whether I needed chemotherapy or not. And this test also, the test was actually done in the US. So the samples were sent to the US, and we're expecting the results around the same time when I was supposed to see Mr. Jahan for feedback. That's about 10 days later after the surgery. So 10 days later was the 2nd of January. And my sister Becky now drove me to Kingsmill Hospital. And coincidentally, my brother had been there, to support me as well. He came in on the day of the surgery. So he was returning on that 2nd of January. So we had to drop him off first at Birmingham Airport. Of course, he was a nervous wreck because he didn't know what kind of results I was going to get. But anyway, we dropped him off, and then we went off to Kingsmill Hospital. And of course, my dear friend Montio was there. So I had a lot of support, which was very helpful. And Mr. Jahan gave, once again, good news. I'll call it good news. He said, no chemotherapy needed. And for me, that was just a real relief. And it brought a lot of gratitude to my spirit, a lot of relief and gratitude to my spirit. So I was very happy. So with chemotherapy out of the way, of course, I engaged into counseling to heal emotionally and embrace physiotherapy just to regain full movement in my arms, and that went very well. And medication-wise, Mr. Jahan suggested that I take tamoxifen, and it's something which I was supposed to take for 5 years. Now, of course, I went back into my reading and researching. I saw all kinds of side effects, and I'm like, oh my goodness, do I really need to do this? And he explained to me very, very well, the pros and the cons of taking this medication. So I listened to him and I started taking tamoxifen, which I took for 5 years. But within those 5 years, I was visiting Mr. Jahan yearly for a checkup every year. And each year I was free. And at the end of the 5 years, Mr. Jahan said, you know, you can stop, but I recommend that you continue. Take it for 10 years. You take it for 10 years, you have a better cover to prevent recurrence of the cancer. So once again, hey, the side effects were not so serious for me, you know, so I continued taking the tamoxifen for the next 5 years. And here I am 11 years later, I'm still taking the tamoxifen because I don't see any reason why I shouldn't take it. So I'm still taking it, and I'm just going on stronger and stronger than ever, you know. So I must say that my story is one of triumph because of the fact that I did screening regularly. And I did my self-breast exams regularly, and I took care of myself. I was concerned about my health. And that's the advice I'd like to give to anyone who's listening today. I mean, early detection will save lives. I think that's one of the advantages I had because it was detected early enough. And the other thing I want to say is that we all have different beliefs. Some of us are Christians, some of us are Muslims, whatever it is, we believe in one deity or the other. And I just want to say that you cannot pray cancer away. You can't pray cancer away. Either you pray as if everything depends on that prayer while making the right decision and taking action as if everything depends on that action you're taking. There should be a balance. And I believe that's what I did, because that's what it means to have faith. Having faith means you're praying and you're acting at the same time. You can't pray and fold your arms and do nothing. So you pray and you act. That's what faith is. So that's my advice to anyone who's listening. And I also want to say that it's really amazing how resilient the human spirit is, because throughout this journey, I discovered how resilient I was as a human being. And I have come out a much better person. I'm able to, you know, touch lives, impact people in many different ways. After my treatment, I have been involved in, you know, counseling. I've been mentoring a lot of women who are going through this in Cameroon. There's a lot of women who go through this and they don't know who to talk to. So I've been able to mentor quite a few of them. I've been a part of a few support groups. And I'm actually, I work with one hospital, or I do contribute somehow financially in a cancer unit in one of the hospitals in Douala. So all of this, I think, is making me a much better person. And it's as a result of, you know, going through something as difficult as this. So I just really want to thank God, and I just thank my family. I think another important thing is support. I had a lot of support from my family, my in-laws, friends, and that really helped. So that support is very much in these things of experience. So I think I'm going to stop there. I think I've talked for long enough, and we don't have enough time.
Thank you.
So thank you all for listening, and I'm sure we have some questions. Thank you.
Yes. Thank you very, very much. If we were in a hall, I think everybody would be standing up and giving you a standing ovation. So I think we can give you a standing ovation here from CamDocUK, not just because you are an amazing person, but because of the generosity of spirit that you've had to come on here and share your journey. It's not easy to talk in front of people, not even knowing who the people are. And you don't know, as you say, the impact that you have made. There are so many comments in the chat. The first one that came through when you were talking was an attendee who just said goosebumps. And I think that was the general feeling of the room when they were listening to your story. Really special to hear your experience. Thank you so, so much for sharing.
Thank you.
Now, somebody did ask a question in the Q&A. They missed it, but what age were you at the point of diagnosis?
I was 47 years old at that time.
Thank you very much for sharing. One other question that comes through is really one that says, this is a great testimony of triumph over breast cancer. Do you think you would have had the same outcome in Cameroon? And what is your advice for those who don't have the financial means to seek treatment abroad? You are an inspiration. I mean, obviously, that is a difficult question because it is a multifaceted question. It's a difficult question to answer. And I think that at some point, when we possibly have the discussion with Dr. Munouh at the end, we might be able to tie that in. So anonymous attendee, please hold your horses on that one. The other thing that has been, another question is, what advice would you give to anyone in a similar situation who is struggling with the religious versus scientific issues with cancer? And again, I think that might be something that we get to when we all have a conversation later. Thank you very much for your story. Thank you very much for sharing your story. And we will come back to you. Did you want to pick up on any of those points so far?
On any of the questions, sorry?
Yes.
Yes.
Really, possibly the one about what would you advise people who are having this tussle between the stay in Cameroon, pray and live, go abroad, have surgery and die? How would you advise people now? I think you've already touched on it.
Yes, I think I did. I talked about faith. Faith means you pray and you act. It's just like, I mean, someone who's believing God to bless them with a baby. You say, God, please, can you give me a baby? And you pray and you pray and you pray, and you do not have intercourse with a man. How are you going to have a baby? You understand? So there has to be, the praying has to go with action. So yeah. God will help you while you're doing what you're supposed to be doing.
Very good point. Very good point. Very, very good point. Absolutely. Now then, we'll come back to when we speak to Dr. Munouh about the financial aspects. We'll come back to that. But if you don't mind, we're going to move on now. And I am so excited to introduce my friend and colleague, Mr. Ali Jahan. It might seem strange that we're calling a doctor Mr., but that is one of the funny things in the UK, where due to history, surgeons were trained by barbers and butchers. And so in deference to those people who actually knew how to do the surgery without knowing the anatomy and the physiology of the patient, surgeons in the UK are termed Mr. and Miss or Mrs. Anyway, so Mr. Jahan is a consultant breast and oncoplastic surgeon and the head of the breast unit at Sherwood Forest Hospitals in Nottingham. That's Kingsmill Hospital in UK. He is an international and national leader in his field and is passionate about research and education. More particularly, he is a warm and engaging physician who takes a really holistic approach, as you've heard from Mrs. Eko, to managing his patient. If you don't mind, Mr. Jahan, I would love you to come on now and give your perspective of managing the breast lump from a surgical perspective.
Thank you for the invitation to present at this forum. And as I said, I've been absolutely mesmerized to listen to Mrs. Eko's story over the last 11 years. Although obviously it's been a great pleasure to be part of that journey.
Yeah.
Throughout that period. So what I'd like to do is cover some of the medical, particularly surgical aspects of the early stage of her treatment.
Yeah.
So without further ado, can you see my slide?
We can see your slides, Ali, but they are right at the end. If you go to the beginning and then put it on slideshow, then it will show us that it's right at the end. Fabulous. There we are. Thank you very much. Over to you.
Thank you very much. So it's been wonderful listening to everyone so far. So I intend not to repeat everything. What I'd like to do is cover some of the things my colleagues have covered, but particularly because Mrs. Eko's experience. And with that in mind, I've got a few headings that I've put there, which I would like to cover in this presentation about breast cancer treatment, early detection, some additional aspects of prevention, and more importantly, where we are heading with this disease. So first thing I'd like to say is, as my primary care colleague has already covered, these are the usual ways a breast cancer may present. But just to repeat, the good news is that the vast majority, 9 out of 10, of breast lumps do not in fact turn out to be cancer. That's really good news. The other thing is, overall, breast cancer is a disease of the postmenopausal ladies predominantly. Although cancer can happen at any age, the risk of cancer in somebody in their 20s, it's 1 in 200,000 approximately. Somebody in their 30s, it's a little bit more common. In comparison, somebody who's in their 80s, the risk is almost 1 in 5. So age and lump is an important factor. So a lady who has found a new lump is been sent to the specialist breast clinic. And my practice is obviously based in the UK, but I try to draw some parallel from what the practice might look like in Cameroon. So lady has been referred with a persistent new breast lump. And as it's been described, she will undergo triple assessment. And what that involves, clinical assessment, imaging, and biopsy. Now, I'd just like to pick up on the biopsy side of things. The reason for the biopsy is, despite what a lump may feel like to the patient, to the doctor, what it might look like under imaging, mammogram or ultrasound, one cannot be sure enough that it is cancerous. So that is why pieces of tissue have to be taken, processed, and the aim of that is to confirm that it is cancer or it isn't, because it's very important to decide what treatment to provide. And thirdly, we need to know which type of cancer, if that's what it is, because further tests may be required before proceeding with treatment. So biopsy is the gold standard. And I know it is an issue in Cameroon and many other developing countries. We'll come back to that. So the other key point, which Mrs. Eko has touched on several times, is the urgency of referral. And here I would say my primary care colleague has covered the importance of self-examination. It is not expected that a lady or even a primary care physician who doesn't see many breast cancers in their lifetime of practice will be expert in breast examination. So here I would say, if there is a concern about any persistent changes, including if a patient complains of a lump, but the GP cannot find the lump, this is a reason for referring this patient on, because there's about a 4% chance that this lady may well actually have cancer. So patient does truly know best. So with those presentation, the patient needs to be moved on urgently to a specialist center for assessment. So we have a patient who's been referred urgently, and on biopsy, diagnosis of cancer has been made. So in terms of preparation for treatment, in the cancer world, it's called staging. I'm happy to say the vast majority of patients in the UK and certainly in Western practice have what's called an early stage breast cancer. So other than an ultrasound scan of the armpit to determine if the lymph nodes are involved or not, no other staging is beneficial. Occasionally, because of certain cancer type, the patient may require additional imaging of the breast with MRI, or where the cancer is suspected to be advanced, then staging CT scan to see if the cancer has spread or not. But generally, no other investigation is required before proceeding to treatment. And talking about treatment, the treatment of early stage breast cancer, the majority is surgery. But the totality of treatment is multimodality, which my colleagues will cover. But for simplicity, breast cancer equals surgery. So what types of surgery are available? So the standard breast surgery, the aim of which is to remove the cancerous lump, the cancer, two, to confirm the histology information we already know. Remember, histology is based on tiny pieces of tissue. Having a bigger piece of tissue gives the histopathologist more information. And this is important to finalize completion of surgery, and two, to determine what other treatment might be helpful in preventing the cancer coming back in the future. So this is like insurance for the future, but you do need this information. So going back to the surgery to the breast, and we'll come back, and surgery to the armpit using what's called sentinel node biopsy, just to assess by removing a small number of lymph glands to see if they're involved or not. Because if they're involved, then you need chemotherapy and other sorts of treatment to protect and treat the rest of the body. Now, coming back to the breast itself, so I'll just move on very quick to the next slide. Yeah. So this is the slide we're talking about. So generally, there are two options. You can remove the cancer as a lump, what's called a lumpectomy, and add radiotherapy. That's package one. Or alternatively, if the cancer is too big, or if the patient prefers to have the whole breast removed, possibly to avoid radiotherapy, possibly for a peace of mind, then there's the option of removing the whole breast. We would, as Mrs. Eko said, we did have discussion, and the discussion is that as far as surgery is concerned, more is not better. But if that's what gives them that peace of mind, and we talked about empowerment, I think Mrs. Eko has touched on, it's very important to have that choice. So the patient is important in all the decision making. Luckily, in breast cancer, we have lots of choices, and that's a good thing. But unfortunately, when a patient has been ambushed by a new diagnosis, this can prove to be difficult in the short term. So that we have a lot of support. Family support has been touched on. There is professional support in terms of specialists, counselors, etc., who are available to support the patient through this maze of choice, which are important, because the reason for making the right choice at an early stage is, as Mrs. Eko's wonderful experience shows, 11 years on, she's disease-free. So although one is consumed by cancer, we as professionals carefully highlight that we hope and we predict that person is going to have a near normal life expectancy. So being a woman, having a normal-ish looking breast, having a breast full stop, whilst not important initially, very soon becomes important. And if the wrong treatment is done, it's difficult to undo. But there are things we can offer. So we talked about reconstruction. This is building up to minimize defects after a lumpectomy, or building up a new breast mound after a mastectomy. And in terms of choices of how to do these, I don't want to bore you with details, but the techniques for this type of surgery, this is where the word oncoplastic comes from. One time, surgeons were breast surgeons, and they would simply remove the cancerous lump. Now we are able to combine both the cancer removal and dealing with the defect, either initially or subsequently. So just like to go back to the previous slide and touch on, continue on the treatment. So you've had your diagnosis, you've had your cancer removed, the diagnosis confirmed. What's next? The next is, as Mrs. Eko's experience shows, there is a discussion about what insurance treatment can be offered to minimize the risk of the cancer coming back. We tell the patient, and this is for cancers across all tumor sites, following successful treatment of cancer, which is usually surgery, there is a risk of it coming back in the future. But luckily in breast, we have whole array of things that can be offered as insurance treatment, such as chemotherapy, radiotherapy, endocrine, etc., which will be covered later. These are all aimed at reducing future problems. Nevertheless, the patient, whilst is encouraged to continue with life normally, support is offered in terms of follow-up to assure them, to answer any questions, and also provide examination and mammograms of the breast treated. But in Mrs. Eko's case, she had mastectomy. It is keeping an eye on the other breast and also providing additional support on the insurance type of treatment. So I'll just touch on breast screening. Now, breast screening is really aimed at detecting cancer when it's still small, because at this stage, treatment is very simple, usually surgical, and no other toxic insurance type of treatment is needed. But most importantly, for small cancers properly treated, the life expectancy is almost that of the normal population. So it is really worth striving for this. I know breast screening may be very patchy in Cameroon, but this is something worthwhile to aspire for. Next thing, just a little bit more on the cancer detection through the screening program. If a cancer is detected through the screening program, as opposed to allowing it to develop into symptoms, you are reducing the risk of death by 23%. And this is the best kind of screening of all the screening programs for bowel, lung, etc. So family history, the important thing to note is that, as it's been mentioned, breast cancer is a common problem. So if there is a family with multiple females, it's a bit like common cold. If you ask anybody in the family, have you had flu or cold? Somebody is bound to say yes. Now, breast cancer is actually relatively common. So if there are multiple females in a large family, purely by chance, somebody else would have had breast cancer. But that does not mean there's a faulty gene running in the family. In general, the vast majority of breast cancers happen purely by chance, and only about 10 to 15% due to something in the family. Now, I think there was a question earlier on, how do we suspect there may be a funny gene running in the family? Simple things, if there's a history of male breast cancer, that is something to consider, or multiple female members, particularly when they're below the age of 50, and or history of ovarian cancer. And probably not such a common problem in Cameroon, but Ashkenazi Jewish heritage is another risk factor. So these are things which may cause a ringing of the alarm bells. There may be something, but if suspected, the best thing to do in the UK, even the GPs are able to do triaging risk assessment very easily. In our hospital, we have developed our in-house very rapid 30-second triaging families to risk assessment. We'd be happy to share this for free with our colleagues in Cameroon. It involves asking 3 or 4 questions, takes only a few seconds to reassure the lady as to whether they are population risk or increased risk. In terms of what can we do, it's already been covered, reducing the risk of breast cancer. The only thing I would say is chemoprevention. Using one of the anti-breast cancer tablets is a new option for significantly reducing whatever your increased risk is, in addition to lifestyle changes. So where are we going with all this? Well, I'm happy to say that if you look at survival from breast cancer over decades, every 10 years, if you look at the curve, there's a big jump in survival. If you look at last 30, 40 years, it's just going up and up. And as I said, the overall survival rate for early stage breast cancers, lymph node negative, small, less than 50 millimeters, up to 97%. Now, in contrast, as Mrs. Eko touched on something very important, it's the word cancer. There are more deadly diseases which are not cancerous. For example, motor neuron disease. The average life expectancy is about 2.5 years from diagnosis. This is what Stephen Hawking had. He was very lucky. He was an exception in that respect. So there are many non-cancerous disease, multiple sclerosis, for example, which can actually kill people. Whereas breast cancer in the early stage, it properly treated, it does not significantly impact on your life expectancy. So early detection is worth striving for. And as I have noted, we are moving from less destructive or mutilating surgery to surgery which leaves the patient with more normal looking breast. And as a result of all this and all the support we can provide, the treatment journey is both physically and psychologically more tolerable. And obviously all this is important if you are going to carry on with normal life. And as Mrs. Eko said, she was never really ill with this lump, and she is not ill after her treatment, and that remains our goals. Just one quick word about clinical trials. If you are offered the option of taking part in a clinical trial, please do that. Despite what the name suggests, it is not really a trial. Clinical trials have reached a stage of safety and effectiveness by the time it's offered to you. It is an experimental form of treatment that is only offered through this route. And in that respect, what was clinical trial medication or treatment 5 years ago is standard treatment now. And this is the thing, the journey of a breast cancer patient, and as with many other cancers, it is very complex with lots of stops. In order to coordinate the sequencing and the decision making, the standard of care is based on what's called a multidisciplinary approach of surgeons, oncologists, specialist radiologists, specialist histopathologists, and other colleagues. And this model of working has demonstrated to show the best outcome. And for Cameroon and other similar countries, these need not be available everywhere. It can be centralized. You can dial in, while some of the first-line treatment and such as surgery with appropriate support can be provided elsewhere. So this is the important thing. It needs to be MDT-based and MDT-led. So in summary, this is a common problem, but the good news is that if it's referred early for assessment and treated properly, usually quite in a simple way, the overall outlook is good, and all this needs to be coordinated by a group of specialists. Thank you very much for listening to me. I'll be happy to answer any questions later.
Fantastic. Thank you so much, Ali. I was spellbound all through your presentation. We had said you had 10 minutes. You went on to about 15 minutes, but we could not miss any of those minutes because they were absolutely fantastic talk. And the chat box is popping with excellent presentation. And thank you, Mr. Jahan, and so on. If you wouldn't mind just stopping sharing your screen for us a minute. Fantastic. Thank you very much. We do have some questions. And of course, finance is one of those that is coming up. How much would it cost for, was it a big burden for Mrs. Eko? How much would it cost for her to have the treatment in the UK? Would she have been able to have that treatment in Cameroon successfully? And then the other side of that question to Mrs. Eko is, what is your advice for those who don't have the financial means to seek treatment abroad? So if I can come to you first, Mr. Jahan, and then we'll go to Mrs. Eko later.
The short answer is, I think with modest amount of support to colleagues in Cameroon in organizing this type of care, and modest amount of support to our surgical colleagues where needed, I do believe this type of treatment can be and quite easily should be accessible in Cameroon.
Thank you for that. We'll probably come back to that discussion once we've had Dr. Munouh do his presentation. There's one specific question here for Mr. Jahan. Why is the age for screening in the UK not 40 for women like in the US, especially for Black women?
Yeah, so on the question of screening age, this was a political decision. So the screening program in the National Health Service screening program, when it was launched in 1991, there was quite good evidence that the mammogram interval should be ideally about 18 months for those who are less than 40, and that even for those who are in their 40s were benefiting from the screening program. So it was a question of affordability.
Yeah. Okay. And as everything, it boils down to finances. Now, again, the question over to you, Jackie. What is your advice for patients who do not have the facilities or the financial ability to go about it the way you did? I think that question is going to come up and up, so we might as well tackle it.
Okay, thank you for this opportunity. I must say that cancer is treated in Cameroon. So once you have, they should approach their doctors. I mean, I belonged to a group of women. We called ourselves Marraine de Cancer. That means like godmothers of cancer. And this was a group of women who were survivors of cancer. And I was the only one who had done my treatment in the UK. The rest of them had been treated here in Cameroon, in hospitals we know in Douala. So I believe cancer can be treated in Douala. We have doctors we have patients who have been successfully treated of cancer in Cameroon. So I think it's just, being very careful about how you choose your doctor, how you choose your hospital, and actually doing the research yourself so that you can contribute to making decisions about your treatment.
Fantastic. That's a great answer. Thank you so much. And I think possibly that there might be more insights into this after we have heard from our next speaker. I must actually, however, just round up this part of the session by saying thank you very much to Mr. Jahan. The take-home messages for me are early detection, which has been hammered through before by Dr. Timi and also from Mrs. Eko, and that there is hope. Also, that as an easy segue for myself to go into the next speaker's presentation, is that management of this condition is usually done in a multidisciplinary fashion. So you would have a surgeon, you would have an oncologist, you would have a nurse, you would have a radiologist, and we are absolutely privileged today to have Dr. Foma Munouh Kenne, who trained, as I said to you, in one of the first and foremost medical institutions in Cameroon at the Yaoundé University Medical School. He trained as a doctor there and then underwent specialty training in histopathology. So he was one of those doctors who was looking at the samples that are sent from after surgery. He trained in histopathology in Cameroon before relocating to the US, where he again did another subspecialist training in hematology oncology. He looks like a baby, but honestly, he has a wealth of experience under his belt. Experience is not the only thing under his belt. He is absolutely passionate about the management of patients with all sorts of cancers. And he currently practices in Albuquerque, New Mexico in the United States, but is very actively involved in supporting the cancer centers in Cameroon that Mrs. Eko just spoke about. Without any further ado, it is my pleasure to introduce Dr. Munouh Kenne Foma, and I'd like you to take it away from here, please.
So thank you, Dr. Montio, and I just want to thank CamDocUK, and I feel like I have to be a member of this wonderful thing you're doing. So I've always been a big fan, and really have been part of those who sit by the bench side and actually encourage CamDocUK for all what you do, especially what you did in Cameroon during the COVID pandemic. So today I will try as much as possible to talk about how cancer is being treated in a multidisciplinary way and also highlight the situation in Cameroon. What I always say when I deal with cancer is try to present case scenarios. I'll be very brief with the following case. So here is a lady, just like Jackie, who got breast cancer and actually had the opportunity to move to the US. She was 60. She did get a lumpectomy. After the lumpectomy, she did her hormonal status, which is very vital. If there is any message I want to pass across today is that please, the pathology is key. After training as a clinical pathologist and also being an internist and a cancer specialist, I think this is where we're lacking. Even back home in Cameroon, even after women get proper treatment, then after surgery, she had radiation. So lumpectomy plus radiation is equal to mastectomy. That's just one message I want to pass across. And she got an oncotype. As you hear, Jackie talked about that word oncotype. We use that test to determine if you're going to need chemotherapy or not. She did get that, and it was low, so she never needed chemo. So she got on hormonal blocking agents, which could be an aromatase inhibitor or tamoxifen. This is a good case. Now, case number 2. And sadly, this is how a lot of patients are managed back home. They think they get the best treatment, but they are not. So this lady was 32. She's a friend of mine. She's of late. She got breast cancer. She was bathing and palpated a mass and went to a doctor in Douala who did a lumpectomy, rightly so, but the pathology was not sent out. And the pathology was done locally at La Kenne, and they said she had invasive ductal carcinoma, but no hormonal testing was done. She went home, no additional treatment. She could not get radiation at the time because the 2 radiation centers in Cameroon were not working. Now, what happened to her? 6 months after, she had a reoccurrence and got mastectomy. Same thing went through, no pathology sent for ER/PR disease. 6 months after that, she got bone pain, and because the initial lump was really huge and nobody really did think about it in Cameroon, there is no routine screening. So most patients are diagnosed late. So she had already bone mets. The big question here is, should she have even had the mastectomy or the lumpectomy in the first place? She got chemotherapy. I was contacted in 2021. We sent for ER/PR status in La Kenne, and in Central Pasteur, it was sent to France. By the time we got the result, she died 2 days before I got the result. She was 100% ER positive and 90% PR positive. This reflects what is happening. As a doctor, you could think you're doing good, but you're harming patients. And that's the go-to message. It's not everyone who gets surgery, gets the right surgery, gets the right treatment that they deserve. This lady would have done so well on hormone blocking agents and may have still be alive today. I have patients who are 15 years alive. Now, this has been spoken about. Breast cancer can be in your lobes, in your ducts. These ducts are channels where milk passes. We call it ductal carcinoma inside with DCIS. When they get out of the ducts, we call them invasive cancers. Now, when they are in the lobes, these are the lobes, these are areas where breast milk is produced. For those who don't know, we call it lobular carcinoma in situ. Once they get out, we call it invasive lobular carcinoma. This is just visually showing everyone what this is. As we have said, breast cancer is the most common cancer in women. In Cameroon too, breast cancer makes about 20% of all cancers diagnosed in Cameroon. So it's a public health emergency and needs to be addressed. In Cameroon, not everything is totally not good. I do work with Bingo Baptist Hospital and the regional hospital in Bamenda, and also work with La Kenne. Every Fridays, we do tumor boards where we work as a multidisciplinary team in order to take care of cancer patients. There is an oncologist in Bingo called Dr. Kuya. She's excellent, and she does everything that is needed for these patients to get proper care. And her management has been spectacular, so there are places where people can go. I can't say the same for La Kenne. I've attended tumor boards. It's all about ego and power. So patients tend not to get the best where you think the best should be gotten in Cameroon. So talk to your doctors. There are other centers. There's a Cameroon Oncology Center, so here you would see that majority of these centers are found in the Northwest. Banso, Bingo, there is a Baptist hospital in Mutengene. There's the Mbopi Baptist Hospital. There's the Shanta Bia Foundation that takes care of pediatric oncology excellently, actually. They are very good. They have a lot of resources. So what causes breast cancer? I'm always going to say, if we live long, up to the age of 80, 1 in every 8 women listening to me is going to get breast cancer, sadly. Yes, that's the statistic that lives, if we live long. So being a woman is a risk factor of getting breast cancer. Aging is the biggest risk factor of getting cancer overall. The more we age, you see this for colon and breast, it's not the genes that you talk about. Dr. Ali talked about it, just 20% of cancers are related to our genes. So here are the risk factors that we generally talk about. These risk factors exist in Cameroon. We're getting an aging population. We have dense breasts as Black women more. We are having breast cancer, those who have had breast cancer before, those who have parents with breast cancer. We have BRCA genes, Ashkenazi Jews, but we also have Black women with triple negative breast cancer more common. There are multiple Cameroonians in the US that have done BRCA gene testing and they have been positive. Framini, those are things that exist. We have never done our pool and we consume a lot of alcohol and we're getting overweight. Here, the GPD talk about breast exams. I'm not going to lay emphasis on this. Here, this is just what I call the orange or the lemon diagram. I would like women to take a picture of this. My advice is if anything is wrong with your breast, please, anything wrong with your breast, get it examined. That's just my take. If anything, I call it breast awareness rather than anything. Screening, we have no screening policy in Cameroon, 0. This is from WHO, there's no screening policy. This is where we should start. I was part of the team that advocated with the Minister of Health in Cameroon, and now we have mammograms in almost all regions. Bamenda just had a mammogram in the regional hospital, and I think Boya also had a mammogram. So I was involved as part of the diaspora group in getting these mammograms because I'm super passionate about this. And how do we screen? Still in Cameroon, among everything I listed here, self-breast exams is super important because clinicians also should do breast exams. In the US, we don't really encourage breast self-exams because we have mammograms in every junction. And we don't want women to be doing breast exams, self-breast exams are not doing mammograms. So that's a different discussion. Mammograms are not common in Cameroon, ultrasounds are not common, and radiologists are not trained to properly read them. Because having it is not a problem, but reading it. So self-breast exams, we already had a talk on this. Mammograms are getting available in Cameroon. We have one now in almost all regions. We have private mammograms. There's one in Boya, a private company that just opened up. They're doing mammograms. They're screening for free. Now, this is an important statement I have here for Cameroon, especially for our GPs back home. When a woman is 30 years, she should have risk assessment by their GPs. And risk assessment is understanding their family history. Like the question that was asked, I'm 30, I have an aunt. The question I'm going to ask you is, how old was your aunt when she had breast cancer? Are there any other cancers in your family, including prostate cancer, pancreatic cancer? That draws me to BRCA2, BRCA1, Li-Fraumeni syndromes. We need to know those things and be able to connect them. Now, annual screening in the US, we start at 40. It's even a debate in the US, Dr. Montio, it's a big debate. My association, FASCO, we recommend 40. The task force, which controls public health, recommends 50 still, and at every 2 years, because they are more of a cost-saving organization. So that's really it. So, and here, biopsy is my big message. We should be able to biopsy these patients. Once we see a mass, biopsy them. The biggest problem we have in Cameroon and many places is that we don't know the ER/PR status of our cancers, and they are to. This determines how surgery is going to be done, as Dr. Ali said. What kind of surgery? Do you need neoadjuvant, meaning before surgery, do you need treatment? Or do you need treatment after? So in histopathology, there are several markers that we need to know. And it's important for us to know exactly what type of breast cancer we're dealing with: invasive, non-invasive, what we call stage 0, recurrent, or metastatic. Here, I've already talked about it, the grade. So every woman here should be able to ask their oncologist or their doctors, what grade was it in the pathology? What stage was it? Has the cancer gone anywhere? Is there evidence that I should do additional staging workup because we don't screen? And how are we going to manage these patients back home in Cameroon? We have said surgery is easy in Cameroon. People know how to do surgery. The question is, are they doing the right surgery? Radiation oncology is pretty a big problem. We have just 2 linear accelerators in Cameroon working. L'Hôpital General has not worked for more than 20 years in Yaoundé. L'Hôpital General Douala works, and I have a colleague there, Dr. Myson, and we do have chemotherapy, which is still also a big problem. I'll address that. Hormonal therapy is underused because we don't test for ER and PR status routinely. Targeted therapy is expensive. We'll talk about the price, but overall, you need to combine this. To me, this is the most important diagram I'll always share. Why? Because 70 to 80% of all breast cancers are hormone positive. So majority of them do not need chemotherapy, even in the metastatic setting, unless you have visceral disease. And without testing it, you can't tell me roughly that you're treating patients appropriately. The worst kind of breast cancer is going to be triple negative. HER2 used to be very bad. We have targeted therapy for it. Herceptin in Cameroon is almost 200,000 for a monthly treatment. Who can afford that? So even in Bingo, where they test, they have difficulties for people to afford. Now, triple negative is the bad guy, and it's more common. I know I gave you this statistic, but in Cameroon and Africa, we're realizing Black women have more triple negative disease, more advanced disease. So we need to get our own statistics to better understand how to treat our patients. Here's a summary of how we do approach breast cancer. I know a lot of times this is here just for the clinicians who are here, but what I want to say is for the most common type, which is patients who are ER positive, HER2 negative, hormonal therapy is the key. It's not chemo. Hormones are like light bulbs that are found on this cancer that we can switch them off, and cancer stop growing. Most women get cancers because they are women, because they have progesterone and they have estrogen, and that is how they are treated. I tend to see about 20 breast cancer patients a week, and I do this routinely on women, and we do this test. In the US, majority of our cancers are very early stage. Surgeries, there are multiple surgeries. I did put this in place because in Cameroon, a lot of surgeons tend to do lumpectomy when patients don't get radiation. Lumpectomy alone is not equal to mastectomy. Lumpectomy plus radiation is equal to mastectomy. So this is a controversial topic in Cameroon, and I and Bingo team, we advocate for mastectomy most of the time because patients will never get radiation. Nobody does centenary lymph node biopsies, because you need a tracer and you need a blue dye, and that's not done in Cameroon. So this becomes a problematic where everyone get an axillary lymph node. So, but there's things that are being done. And the hormonal treatment is underused, as I said. Targeted therapy is expensive. Chemotherapy, most of it is not available. The Clinton Initiative is doing a lot of work to introduce most chemotherapy into the essential drug list, but in metastatic disease, we don't have CDK4/6 inhibitors. We don't have most modern things that we can need to treat patients in Cameroon. But there are people who are doing a good job. So my advocacy is know your pathology, ask questions, and know what your hormone status is. A lot of people are getting chemotherapy when they do not even have to. Radiation is limited in Cameroon. 2 machines, L'Hôpital General Douala, always bad. The private radiology company is there now, and we're encouraging the diaspora to invest and be able to help women. We need subventions for these things going on in Cameroon. Those with metastatic disease, a lot of them get chemotherapy, while a lot of them without visceral disease. 80%, as we said, of breast cancer, or 70 to 80% will be driven by hormones. And these treatments are available in Cameroon, but no one is using them. That's the point. Tamoxifen is available, aromatase inhibitors, but if you don't test, you will not do it. I had a case the other day, has had cancer for long, and she has metastatic disease, but she has been on everything except for us even knowing her hormonal status, and was presented in the tumor board in Bamenda. I asked, what's her hormonal status? So breast cancer survivor is the next thing. Most of us those who have had breast cancer in the US now and in the UK, and most part of Europe, women with metastatic disease are surviving above 15 years. My case, I have a patient on aromatase inhibitor alone. I've never added a CDK4. I'm just inheriting her into my practice. She's 15 years, she's going. That's what we are seeing. So it's a combination of therapies we use. I can spend weeks talking about breast cancer. It's complex. So it's multidisciplinary. We need to get palliative care team involved. We need pain specialists that are not trained well in Cameroon. We need radiation therapists. We need surgeons that are trained as breast surgeons, not general surgeons. We need to insist on that. There is a big difference. And oncoplastic surgeons, there's a big difference. We need pharmacists that are oncology pharmacists to be trained. We need a multidisciplinary team. Cameroon has a national strategy for breast cancer. I was asking the minister, how are we going to update this? Because this was done that by 2024, we'll have a plan. It's a big document. I can share it. Nothing changed. Nothing. If you look at the prevalence of breast cancer, it's higher in the Northwest just because they are taking patients' reports. So this is more of reporting patients in Bingo and in Bansor. So that's why, because most cancer patients are treated there appropriately. So it's a biased report. It's not true that most cancer patients are in the Northwest. We do lack personnel. If you look at this, we lack personnel. Most of them are going abroad like myself, and it's not good for the country. And we do lack basic MRIs. There are just 3 functional MRIs in Cameroon. They increased the number. There are few functional CT scans. The number increased with the African Nation Cup, but there is a lot to do. These are centers that offer chemotherapy in Cameroon. We can talk and I can answer specific questions. I've gone back to the best treatment cancer centers that I know in Cameroon. These are them. And I'll tell you that L'Hôpital General Douala is not there. L'Hôpital General Yaoundé is not there because they are not practicing holistic care. This is the Cameroon Oncology Center. I have no affiliation with them, but they are doing a great job. Now, my take-home message is that the National Cancer Plan is in development. Budget for cancer program in Cameroon does not exist. Monitoring and evaluation does not exist. Screening, we don't screen for any cancer in Cameroon, neither colon, neither breast, nothing. And that's the best way we can make a difference. Radiation therapy is limited, chemotherapy limited, pain management limited. If you want to get a morphine in Cameroon, you'll be very surprised. Screening to me is essential. Knowing it exists is not enough. Getting informed, especially the patients, is important. If anyone takes a tissue out of you, tell them to send it to pathology. That's a take-home message. And you should know what it is. It's not routinely done in Cameroon. I just want to thank you. Prevention is better than cure, and I think Cameroon needs to prevent cancer. Thank you very much.
Wow. 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 I warned you. I said he was passionate, and I was holding on to my seat all through that roller coaster ride, through such a fantastic depiction, although it felt like a cold shower after the previous speakers. It really did feel like, what are we going to do in Cameroon? Our system is a little bit behind from the point of view of screening, from the point of view of histopathology, from the point of view of training and manpower, as well as just the resources to manage our patients. So this is something that we have. There's a lot of work. There is a lot of work to be done. Now, having said that, there are a few questions, and I think you must have also answered. You must have answered this about the new oncology center in Douala. But there's a specific question about concerns about radiation treatment in Cameroon, and where would you recommend? Would you be able to comment on this, Dr. Munouh?
Yeah, for now, I would recommend the Cameroon Oncology Center because they have a good linear accelerator. They are putting efforts to be able to actually treat patients. Bingo is going to get one in the next year, I think so. They already have a bunker built. So they are working with an association in the US in order to help them get a linear accelerator. L'Hôpital General Douala, they're doing everything to get themselves functional. It's one of the best general hospitals in Cameroon that always works. I have a colleague there. That's Dr. Maison Maye. She's a radiation oncologist. She works there, and there are others too who are there. So with those 2 centers, you will get something that you can get going, but the lines are impossible. The number of patients that are waiting for treatment is impossible, and fractionating and having connections becomes the next thing.
Okay. Thank you very much for that answer. There are 2 questions also which have been in the Q&A box, and again, it's down to finance and down to money. There's a question, how much does a chemo or radiotherapy session cost in Cameroon? And do we have a PET scanner in Cameroon?
No PET scan in Cameroon. That's an easy one to answer. PET scan in Cameroon. And I think closer to Cameroon, Nigeria has about 2, but no PET scan in Cameroon. It's pretty expensive. There's none. And getting into cost, it depends on what chemotherapy you're getting. It's become, it's sad to say this, but it's become a personal money-making business for oncologists on what to give you. And it could range from 300,000 to nothing, depending if you have metastatic disease and you have to keep going to millions. Most Cameroonians are going to India, from what I see recently, in order to get treatment. And if you're going to get targeted treatment, it's not even available to get trastuzumab, basic trastuzumab that we have had in the world for more than almost 20 years. We don't have it in Cameroon accessible. People have to get treatments for 250,000 CFA, which is not affordable. And things like immunotherapy are totally non-existent, despite the number of years that we have had immunotherapy. So we need a lot of...
There's a lot of work to be done.
But there are people who are doing great things. Bingo in particular, Bingo Baptist Hospital is doing great things and great efforts in order to get this done. L'Hôpital General, Douala too, but you have also the Cameroon Oncology Center. So it's not towards, but a lot of these patients would get hormonal treatment, just that there's no routine testing. That's the sad part that you get, is that most of them do not even need chemotherapy. As we said, 70% of breast cancers are hormone positive.
Thank you so much for that answer. And you know, it really brings it home to me about how much work needs really to be done, as you said. There's one question here from Claire, and I think that this is addressed to Mr. Jahan. How long after a mastectomy can one do breast reconstruction or enlargement surgery? Also, how long can one do breast reduction surgery after a lumpectomy?
Montio, I think I've answered that in the chat box, but I'm happy to repeat it. But basically, the standard of treatment nowadays is that the patient should be offered the option of what's called immediate at the same time as cancer surgery, breast reconstruction, including a reduction, which usually means reduction of the other breast. Or it can be delayed, and there are no differences in the outcome.
Splendid. Thank you very much for that answer. As I alluded to at the beginning, it would be difficult for us to deal with all the questions live, but my team of amazing behind the scenes doctors and support have been answering your questions, and I hope that these have been coming up. One question that I quite really was very keen on answering live was one from Pastor Abby, who asks about email reminders and whether a database could be set up for reminders for those who would like to have that. For example, NHS reminding people who would like checks. Now, from what I understand from this question, this really is down to the NHS screening system, which is it's a huge system which the GPs even are not involved with. It is we actually have specialists who are set up, public health specialists who deal with this screening. They send out reminders to patients and so on. So that's the best way in the UK to have your screening done. I hope that answers your question first. So I have been informed, I've been told that you must please do the poll on the SurveyMonkey, that the link is in the webinar chat. If you could please do this for us. What it does is it makes us a lot more responsive as an organization, and we at CamDocUK are a listening organization, and we want to be able to continue being in contact with our community. And so please fill in the please fill in the questionnaire, the poll. Mrs. Eko, there's a last question coming in. How can we get in touch with your organization? And this comes from an anonymous attendee. I'm not sure whether what organization they actually mean. Mrs. Eko is the Prime Minister.
Oh my goodness.
The headmistress of a school in Douala. And certainly, if you wanted any contact with any of our panelists, if you contact CamDocUK, or if you put your email address in the chat, then we can be in touch with you. So if anybody wants any contact with any of our webinar panelists for any further information, please put your email address or your contact details in the chat and we can pick it up and we will be in touch with you. So in general, it's the same old thing. Don't call us, we'll call you, but we do promise to. There are still questions coming in through hard and fast. If we have one, can we get a copy of the various presentations? Certainly, yes, we can. Oh, fantastic. Les Marraines de Cancer is the one that is being requested, the contact from Les Marraines de Cancer. If we can get the contact for Les Marraines de Cancer, if you've got that, Mrs. Eko.
Okay, I think they need to contact me directly. So if they can give their email, I can contact them actually to give that information. Yes.
That's great. That's great. That's great. So are we having any email addresses coming through? We've got one for Claire. So if Linda can pick that up. Can you pick that up, Linda? Claire, so we will contact Claire. And we also have one from Mr. Anago. So we've got the contact so we can be in touch and give you some further information. Fantastic. We are actually 15 minutes over our supposed ending time. And it looks like the time has flown just because our panelists, our stories, our engagement has been so fascinating. I think it is only left to me now to thank you all really very, very much for spending your Saturday evening with us. Mr. Jahan has had to leave his family who are celebrating Eid, the end of Ramadan celebrations. And just because of CamDocUK, he has come into his office. You can see he's sitting in his office in the hospital doing this webinar. So we have to say thank you very much. Dr. Munouh is halfway around the world, across the pond, 7 hours behind us. And we have been chasing him relentlessly to meet us, to come and join us for this webinar, and he has provided and he has really shown up with all the passion that we expected. Mrs. Eko, your story made people actually have goosebumps. They were, people have been impacted by your story, and I am, for one, as your friend, I'm really proud of you, and I am delighted that you took this step to come and tell us your story today. Finally, last but not least, Dr. Manka Timi, who kicked off the deliberations today with a wonderful roundup of breast lumps and how we deal with them in primary care here in the UK. And I will then now just say thank you very much also to Dr. Bello, Dr. Nana, Dr. Mafo Foma, and Dr. Anambene, who have been absolutely fantastic behind the scenes, working and pulling all the strings to make everything look so seamless And me here in my pink shirt, I'm saying good night. Thank you very much for coming. And we look forward to seeing you at our next CamDocUK webinar, which I can whisper will be about endometriosis. Ah, you didn't know what that was, did you? Google it and come and join us. It will be very, very educative. Thank you very much and goodbye.